Thank you very much for the very kind invitation to be here and for your introduction. It's my pleasure to be here to discuss a fairly timely topic, and as the title here indicates, dissecting the benefits from chemotherapy in premenopausal patients with hormone receptor positive HER2-negative breast cancer, and put that in the frame of a newly launched, almost now a couple of years, trial, the so-called chemo offset trial. We'll have some discussion of that. Here are my disclosures. And we'll start essentially with the good news. And of course, the good news is that there has been an important evolution in breast cancer treatment with the adoption of systemic therapy, obviously minimizing the extent of surgery, and also with improvements in imaging and early detection. But more importantly, adjuvant systemic therapy, we have seen now that the rates of local regional recurrence, distant recurrence, and breast cancer mortality have continually declined, since, as you can see, in the mid-80s to here 2015 in this publication. So these are the good news, but the bad news is that with every advancement in the adjuvant treatment, improving the survival curves, the next advancement has to treat a significantly larger number of patients to benefit a few. So selection of appropriate candidates becomes a very important component in our approach to treatment. Of course, the portrait of breast cancer changed when we realized the work by Sorley and Peru, that there are different intrinsic subtypes based on the expression of DNA in these patients, and categorizing patients, as you can see, into the basal, the HER2 subtype, the luminal A, luminal B. The normal subtype actually probably did not pan out to be a true subtype. And as you can see, these different subtypes also had different outcomes. Of course, this is with a treatment of several years ago that has changed substantially nowadays. And of course, as a result of these observations, several genomic classifiers have become available, and they're primarily, as you know, used in patients with hormone receptor positive and HER2-negative breast cancer. We'll talk a little bit about their clinical characteristics and what they can do for us. And as you can see in the order they appear here, the 17-gene prognostic index of mammoprin, the 21-gene recurrence score Oncotype DX, the breast cancer index, which is a combination of the ratio of the homeobox 13 interleukin 17B receptor and molecular grade index, the A-gene assay EndoPredict, and the PAM50 assay Prosigna. These are the main commercially available genomic classifiers worldwide. All of this now can be done in fixed paraffin-embedded tissue. Initially, the mammoprin required fresh tissue, but eventually they converted that as well in paraffin-embedded tissue. So what is the clinical utility of those commercially available genomic signatures for early-stage breast cancer? They can do the following. The majority, all of them, I think, as you know, have been developed to predict risk of distant recurrence. That was essentially the main goal of all these assays. In the process, though, of studying and evaluating these assays, we have seen that some of them can also predict benefit from adjuvant endocrine therapy. Some predict benefit from adjuvant chemotherapy. And of course, there is also prediction of risk of local regional recurrence, which very well correlates with risk of distant recurrence. And also, some of these assays can predict risk of late recurrence and potentially even benefit from extended endocrine therapy. So I'll focus a little bit on the 21-gene recurrence score because this is the one that we have the majority of the data that drive our clinical practice. And as you know, the 21-gene recurrence score has been validated in one of the older NSABP trials, the B14 trial, in patients treated with tamoxifen, showing that intermediate, low, intermediate, and high recurrence score have different outcomes. But more importantly, this score was shown, as you see on the right side, that it fit better a linear model, and the risk of recurrence progressively increased as the Oncotype DX or 21-gene recurrence score went up. So it was a continuous variable rather than a dichotomous or trichotomous variable. Of course, there are cutoffs, and we'll talk about different cutoffs as we move on, but in essence, this is a continuous risk assessment. Now, some of the early studies from the B14, early results from the B14 trial also showed that the recurrence score appears to predict also benefit from tamoxifen for endocrine therapy. As you can see here, distant recurrence-free interval was seen an improvement with tamoxifen with recurrence score under 18, as we can see to the left here. There was benefit from intermediate recurrence score, 18 to 30, but patients with recurrence score of 31 or higher did not appear to have much benefit from adjuvant endocrine therapy. It's important to remember this, although this did not change our practice. We did not stop giving adjuvant endocrine therapy in somebody that has a recurrence score of 31 or greater, because we obviously prevent contralateral breast cancer with adjuvant endocrine therapy, and we probably needed a lot more data to be absolutely clear that there is no benefit there. However, as you can see here, the interaction p-value was borderline statistically significant. Now, we have seen this also in the clinical setting. This is one of the studies. We'll discuss some of that tomorrow when we talk about neoadjuvant therapy and genomic profiling. And as you can see here, this is a study showing that clinical response to neoadjuvant endocrine therapy depends on recurrence score. You can see that clinical complete and partial response in the black bars, it's much higher for recurrence score low, and 55%. It was 42% for intermediate recurrence score, and dropped to about 22% for high recurrence score. And again, the recurrence score was a significant predictor of benefit from endocrine therapy, as we can see on the right. But the more important finding, I think, as we developed these genomic classifiers, was the ability to predict benefit from adjuvant chemotherapy, and that made a big difference, because ultimately that's why we did these assays. We did them to find out who needs more than adjuvant endocrine therapy, which is the mainstay of therapy. And these are results from the NSABP B20 trial that compared chemotherapy plus endocrine therapy to endocrine therapy alone. Overall, there's about a 5% absolute difference, but then when we looked at it according to the recurrence score, as you all know by now, there was no benefit in the low recurrence score patients. There didn't appear to be much benefit in the intermediate recurrence score patients, as you see here, 18 to 30, and pretty much all the benefit came from patients that had a recurrence score of 31 or higher, to the point of about a 75% reduction, relative reduction in these patients, and a 28% absolute benefit. So that changed essentially how we view this, because patients that had high recurrence score seem to benefit from chemotherapy, and they should get it. Patients with a low recurrence score do not. And we were a little bit uncertain what happens with the intermediate recurrence score patients, and we'll discuss the trials, as you know already, that have been launched and completed, showing us more important information for this subgroup of patients. So this was for non-negative patients in the B20 study, but also similar data was shown in a SWOG study, SWOG 8814, in patients with positive nodes. These were postmenopausal patients with positive nodes. And again, comparing chemotherapy plus endocrine therapy to endocrine therapy alone. This was CAF plus tamoxifen versus tamoxifen alone. And as you can see here, very similar results. Low recurrence score patients don't seem to have benefit. Intermediate recurrence score patients as well don't seem to have a lot of benefit, but most of the benefit came from the high recurrence score patients that we see here, 31 or greater. You see the benefit here. So we were pretty convinced that low recurrence score patients don't need chemotherapy and do well. High recurrence score patients benefit a lot, but what about the intermediate? And this was, I think, as you all know, where the TAILOR-X study provided very important information. And this study took patients with ER-positive or negative breast cancer, node negative. If the recurrence score was less than 11, they gave them adjuvant endocrine therapy alone. If the recurrence score was over 25, they gave them chemotherapy plus endocrine therapy. And if the recurrence score was 11 to 25, they were randomized to either endocrine therapy alone or chemoendocrine therapy. So now the cutoffs here are a little bit different. It's 11 and 25, not 18 and 30. But this was done mostly to be conservative and not deprive patients with potentially getting some benefit from chemotherapy or being given chemotherapy. That's why they dropped the cutoffs to 11 and 25. And of course, when the results of this study were first presented and published in 2015, looking at the low recurrence score patients, 15 or less, you can see excellent outcomes. The 5-year outcomes was 99.3% just with endocrine therapy alone, further validated the prognostic significance of the test. But then eventually the primary results of the randomized component became available. These are the 9-year data. And you can see that there's absolutely no difference between the endocrine therapy alone group or the chemoendocrine therapy alone group in terms of the 9-year invasive disease-free survival or the 9-year distant recurrence-free interval. You cannot see any separation between the two curves. However, subset analysis according to age and menopausal status eventually showed that postmenopausal patients did not get any benefit from chemotherapy, but premenopausal patients appeared to get some benefit from chemotherapy. And this depended also on the recurrence score value. So for example, for patients with 16 to 20 recurrence score, and this is low clinical risk and high clinical risk, and this study defined high clinical risk between the grade of the patient and the tumor size. If the sum of the two are more than 4, is considered high clinical risk. In other words, grade 3 and 1.2 centimeter lesion is high clinical risk. Less than 4, low clinical risk. So here for patients with 16 to 20 recurrence score, there was no benefit for low clinical risk, but for patients with high clinical risk, there appears to be a benefit, about 6.4% absolute improvement. And for patients with 21 to 25 recurrence score, we see that there was benefit 6.4% for low clinical risk, 8.7% for the high clinical risk. So with that in mind, then chemotherapy potentially would be beneficial for these patients and should be given. Remember that. Now, further update at 12 years, we see that these numbers to some extent are maintained. We see that there is still no benefit for patients with a low clinical risk recurrence score 16 to 20, but the benefit in high clinical risk recurrence score with 16 to 20 is about 3.1%. That dropped a little bit. For 21 to 25, though, the benefit remains 5.9% for the low clinical risk, and it became even more so, 11.7% with those with a high clinical risk because they had more risk for recurrence. Now, an important observation in that study was that when they looked at according to age and menopausal status, and here broken down as follows, these are patients 40, less or equal to 40 years of age, and this is 41 to 45 premenopausal, 46 to 50 either premenopausal or postmenopausal. And as you can see here, the benefit from chemotherapy was seen for patients that were 41 to 45 that were premenopausal, 46 to 50 premenopausal, but not in those that were 46 to 50 postmenopausal, but interestingly, not even in those that were less or equal to 40. So how do we reconcile that? Why didn't these patients get benefit from chemotherapy? Well, one observation that will come back to play as I will discuss this is that these patients with chemotherapy get a temporary, potentially amenorrhea, but eventually their menses return because they're younger and they have high probability of resume their menses. So they don't get a full ovarian suppression from chemotherapy as they do patients with 46 to 50 or even over 50. So remember that. That's an important observation from this study. And this was in non-negative patients. And of course, the next question that needed to be asked, is this also true for node-positive patients? So the Responder trial took patients with 1 to 3 positive node, recurrence score of 0 to 25, they went all the way down to 0, and randomized them to chemoendocrine therapy or endocrine therapy alone. Essentially similar to the TAILOR-X, only for node-positive patients and a different recurrence score. What I showed you, I skipped in TAILOR-X, that about 13% of the patients in TAILOR-X, 13% of premenopausal patients received ovarian function suppression. The majority of the patients, 87%, received tamoxifen alone. And this was true also, as you can see down here, in the responder trial. About 12.7% of the premenopausal patients received ovarian function suppression. Most of the endocrine therapy was tamoxifen, even in this trial, so you have to remember that. So, of course, when the results were presented and eventually published at the New England Journal, we see that there was a little bit of difference, but even not statistically significant at the time of publications. It was a p-value of 0.10, but a little bit better for chemoendocrine than endocrine therapy alone, about 1.2%. Now, of course, the data are still early, and more events will happen eventually, and they will be updated. But when we then looked at postmenopausal versus premenopausal patients, the same pattern was there again. Postmenopausal patients, absolutely no difference, but premenopausal patients with the same type of recurrence score values appear to have about a 5% absolute improvement. Relative reduction was close to 50%. So we still see benefit in premenopausal, but not in postmenopausal. And this was true for recurrence score of 0 to 13, as well as recurrence score of 14 to 25. This is an interesting observation. We were led to believe that low genomic score, like 0 to 13, will have not much benefit from chemotherapy, and yet we do see similar benefit for chemotherapy here in premenopausal patients with 0 to 13, as in premenopausal patients with 14 to 25. So there was no quantification of risk between the two. This was true also according to the number of nodes, either one positive node or two positive nodes, no benefit in postmenopausal, significant benefit in premenopausal. And of course, this data have also been seen as well for another trial, the MINDAC trial that used MammaPrint. And in that trial, there weren't a lot of patients as it was in TELOREX and responders, so the benefit of chemotherapy was somewhat variable, so we couldn't make a big inference. But nevertheless, this trial, as well as the responder and TELOREX, showed the same thing, that postmenopausal patients don't get any benefit from the addition of chemotherapy, but premenopausal patients, or under 50 if you like, in this analysis, do get benefit. It's very consistent between the three trials. So in parallel, there was another development, as you know, and that is the introduction of ovarian function suppression in the early stage breast cancer. Now, this is something that's been done for many years, but sort of the perfect trials were never done. And in fact, they haven't been done even to date, and I'll explain why. But the SOFT and TEXT came as close to be the trials that will provide us an answer about ovarian function suppression in addition to endocrine therapy, and then the question of what endocrine therapy should we use? Should we use tamoxifen, or should we use an aromatase inhibitor? So the TEXT essentially took patients that were having ovarian function suppression and then randomized them to either tamoxifen plus OFS or exemestane plus OFS. But the SOFT trial was a 3-arm trial that compared tamoxifen alone, so essentially the endocrine therapy that most of the patients in TELOREX and responder had gotten, to tamoxifen plus ovarian function suppression or exemestane plus ovarian function suppression. In other words, different endocrine therapy with ovarian function suppression. And as you know, with median follow-up of about 9 years, when they reported the results, particularly the SOFT results, which are very important, showed that ovarian function suppression improved the outcomes of these patients, and indeed improved it more if it was given with an aromatase inhibitor than with tamoxifen. You can see that the benefit of the aromatase inhibitor is about 7% improvement, with tamoxifen was about 4.2% improvement. An interesting observation, though, in this trial was that when they stratified the patients according to the risk, and low-risk patients were treated with endocrine therapy by far, but high-risk patients received chemotherapy and then went to the trial to receive ovarian function suppression. Interestingly enough, the benefit was for patients actually that had received chemotherapy. You can see here, this is the TEXT, and this is the SOFT, the same benefit. And the patients that received no chemotherapy, because they were so low risk, the investigators managed to isolate these patients. They did excellent, and they did excellent whether they got ovarian function suppression or not. But what this shows essentially is that even when you give chemotherapy, there is still benefit from ovarian function suppression above and beyond what chemotherapy can do, and that's a very important observation. Now, another sort of piece of evidence that even tells us a little bit more about the effect of ovarian function suppression and having intact ovaries is these results that were presented at the ASH committee a couple of years ago by Kevin Kalinske, the PI from the Responder trial, looking at the serum anti-Müllerian hormone levels. And AMH, or serum anti-Müllerian hormone levels, is a compound that actually predicts ovarian reserve. So despite of the age of the patient, the AMH can tell you if the patient is about to be in menopause or is actually true postmenopausal. It's a much more sensitive assay than the assays that we have estradiol, FSH, and LH. So the study that in the Responder trial, and to make a long story short, what they found was in younger perimenopausal patients, if they had low AMH, essentially indicating that there's no ovarian reserve, there was no difference with the addition of chemotherapy in the Responder trial. But there was a significant difference for patients that had high AMH, meaning that they still have ovarian reserve, so they were considered premenopausal. And this was a 7.8% improvement. So this is actually another factor that actually can make the argument about ovarian factor suppression even stronger. So the last piece of evidence that I need to show you before I get into the trial is response to neoadjuvant chemotherapy. We know from many, many studies that achieving a pathologic response to neoadjuvant chemotherapy is a factor of chemotherapy sensitivity and is a factor that predicts excellent outcomes. So the question is, for the ER-positive, HER2-negative patients, can we use neoadjuvant chemotherapy as a surrogate of chemotherapy benefit in pre- versus postmenopausal patients with a low recurrence score under or equal to 25? So is this true? If that was the case, that premenopausal patients were more sensitive to chemotherapy, then they should probably have higher pathologic response rates. But is that the case? Well, several studies have shown, and I'll show you some here, that the 21-gene recurrence score and other genomic classifiers, I don't have time to show you all the data, but the 21-gene recurrence score predicts pathologic response to neoadjuvant chemotherapy. This results from Luca Gianni from the ECTO trial, showing that the red dots are pathologic complete responders, the yellow dots are no PCRs, and there were no pathologic complete responders under 25 of recurrence score. And most of the pathologic complete responders was in the higher end of the recurrence score, as you can see here. This is true for clinical response in Jenny Chang's study with docetaxel. Again, no clinical complete responses over here, a lot of them over here. And then there was another study by Denise Yardley looking at ixapepilone and cyclophosphamide, and they did the recurrence score for these patients and showed essentially that with recurrence score under 18 to 18 to 30, there were no pathologic complete responders. Only over 30, we see pathologic complete response. And then more recently at the San Antonio meeting, there was a presentation from the ADAPT trial from the West German group. And the ADAPT trial is a little bit complicated, but I'll try to explain very briefly what it shows. So what they did in the ADAPT trial, they used response to short course of neoadjuvant endocrine therapy in terms of Ki-67 reduction, and they also looked at 21-gene recurrence score as a two ways of classifying patients that low risk of recurrence were treated with endocrine therapy or high risk of recurrence that should be treated with neoadjuvant chemotherapy. And to make a long story short, this is the neoadjuvant chemotherapy part. Anybody with N2 disease went there, but also if you had the recurrence score other than 25, but you did not respond to Ki-67 reduction with neoadjuvant endocrine therapy, you went there. And again, if you have 12 to 25, you could also go there again if you did not respond. So this group of neoadjuvant therapy was heterogeneous, had patients with recurrence score over 25 and patients with recurrence score of 12 to 25 that did not respond to Ki-67 suppression with neoadjuvant endocrine therapy and also high stage patients as well. And so what they found was the pathologic complete response was much lower for patients who had a recurrence score of less or equal to 25, and you saw how they got into the trial, and much higher for those that had a recurrence score over 25, 7.2% versus 16.1%. But in this trial, they included premenopausal as well as postmenopausal women. So when you look at the pathologic response according to menopausal status, what we see here that in premenopausal patients, and I think that has to go here, yeah, you can see that the premenopausal patients had only about a 4.8% pathologic complete response. Similar postmenopausal patients with recurrence score at the 25 had almost double the pathologic response, 12.2%, and of course for the over 25, the higher responses. So again, this indicates that pathologic complete response here is not a surrogate of efficacy of chemotherapy. So it may not be a chemotherapy cytotoxicity effect, but perhaps something different, as in potentially ovarian function suppression. So based on these results that I mentioned to you, the TAILORx, Responder, MINDACT, soft text, and the neoadjuvant trials, it is reasonable, I think, to hypothesize that the observed benefit from adjuvant chemotherapy in premenopausal patients with low to intermediate genomic score may be either in full or in part the result of indirect endocrine effect of adjuvant chemotherapy on ovarian function suppression. In other words, chemotherapy suppresses the ovaries, and then that endocrine effect results in improved outcome. Of course, this has to be proven prospectively, and to address this hypothesis, we designed the phase 3 randomized clinical trial, also known as NRG-BR009 or chemo offset trial. So I'll spend the last couple of minutes talking to you a little bit about the trial. Now, the overarching theme of the offset trial is that it brings together the recent developments in the treatment of hormone receptor positive HER2-negative breast cancer. Since tamoxifen became the standard adjuvant endocrine therapy, 4 major approaches, as I already showed you, have independently contributed to the evolution of adjuvant therapy in premenopausal women. One is adjuvant chemotherapy. We'll show you the data. One is ovarian function suppression. One is the introduction of aromatase inhibitors for premenopausal women. And finally, the fourth is the introduction of genomic profiling. So in a simple way, the offset trial essentially puts all this together in one trial. It's the last sort of, to me, called the nail of the coffin of chemotherapy, if we can show that it does not make a difference if you maximally suppress the ovaries. So this is the schema of the trial. Premenopausal patients, hormone receptor positive, HER2-negative breast cancer, pathologic and 0 with recurrence score 60 to 20 and high clinical risk based on the TAILORx, or 21 to 25 for non-negative, or PN1 for recurrence score of 0 to 25. In essence, the eligibility is the patients from the TAILORx and Responder that received benefit from adjuvant chemotherapy. And then stratification by nodal status, age of the patients, and intent to receive a CDK4/6 inhibitor, which is a reality now. And then randomization to chemotherapy, ovarian function suppression, and an aromatase inhibitor for 5 years, or ovarian function suppression and an aromatase inhibitor for 5 years. In essence, the rationale for this trial is we're trying to maximize the endocrine therapy with ovarian function suppression and aromatase inhibitor, and then we ask the question, if you maximize the adjuvant endocrine therapy, would you see the same chemotherapy benefit in premenopausal patients that we saw in this trial? So it's a superiority design, not a non-inferiority design, but it requires about 4,000 patients. So again, this is repetitive, not negative, with the recurrence score 20 to 25, 16 to 20 high clinical risk, no positive, 1 to 3 nodes, recurrence score less or equal to 26, less than 26. Now, if you have a mammo print and it's a low risk or MP high, you can enter the trial, but you do need an oncotype to tell us that you fall into these categories so we can then enroll you into the trial. Adjuvant chemotherapy is at the investigator's choice. Any NCCN ESMO guideline regimen is acceptable, at least for cycles of chemotherapy. The choice of aromatase inhibitor is at the investigator's choice, consistent with the drug package insert, but we can switch between aromatase inhibitor, and if you have significant side effects, you can also go back to tamoxifen, radiation therapy per standard guidelines, but they have to tell us what the patient will get before they get into the trial. And whole breast is required. Now, the choice, again, of GnRH agonist is at the investigator's choice. Leuprolide, goserelin, triptorelin, either monthly or every 3 months can be used. Bilateral salpingo oophorectomy is allowed if desired. And again, OFS should be initiated after chemotherapy unless co-administration is desired for fertility preservation. So those patients will allow concomitant use. OFS and an AI should be started concurrently within 4 weeks from the chemo and should be started prior to and given with radiotherapy, but again, there's some leeway in the trial if you want to do it afterwards. And of course, more importantly, serial monitoring of estradiol is recommended to assess ovarian function suppression adequacy. And again, the levels are important. A level of 2.72 is optimal for postmenopausal on an AI, but it's uncertain that most of the assays go that low. So we have to deal with whatever assays they are, and if the assay says it's in the postmenopausal range, we'll take the patients. But we'd like to go back and do serum tests later to see if multiple suppression is even better. So we strongly recommend the use of ultrasensitive mass spectrometry assays. And this is an algorithm of how we manage. If you're not suppressed with the first 3 months, then we can change either from monthly to 3 months and repeat again, or vice versa, repeat again the assay. And if you continue not to be suppressed, then you're either going to switch to tamoxifen, either have an oophorectomy, because you have to be suppressed as part of the trial. CDK4/6 inhibitors are allowed, both abemaciclib and ribociclib, but they have to be told that they're going to get a CDK4/6 inhibitor before they go into the trial. So the intent has to be declared. Bone anti-resorptive therapy, of course, with adjuvant bisphosphonate or ligand inhibitors may be given at the investigator's discretion. And again, this needs to be captured in the case report form. Pregnancy is allowed in the trial. The patients can take a break if they want to based on the results of the positive trial, but recommended to discontinue drug therapy for at least 3 months prior to attempting to conceive. And if they interrupt, they will continue to follow per study, and they can resume study therapy after delivery. And in this study, we don't collect any chemotherapy adverse effects. It's well known. There is nothing much to do. Only collect grade 2 or greater adverse events related to endocrine therapy, and you can see which they are. And again, the routine AE report is not required for arm 2 patients who are receiving only chemotherapy without OFS. So, accrual to this study so far is about 10%. We have about 400 patients in the study. Obviously, we need more patients. The majority of the patients coming to the study are actually not positive, which indicates that people have warmed up to the idea that potentially is an ovarian function suppression effect. But again, we have to prove it. So in summary, premenopausal patients with low intermediate recurrence score benefit from the addition of adjuvant chemotherapy to adjuvant endocrine therapy, whether they're PN0 and PN1. Similar benefit, though, is not seen in postmenopausal patients with the same clinical and genomic profiling characteristics. The patients with low intermediate recurrence score obtain benefit from adjuvant endocrine therapy, as I showed you earlier, and neoadjuvant chemotherapy trials for hormone receptor positive HER2 negative patients with low intermediate recurrence score show low PCRH irrespective of menopausal status. So that we don't see direct cytotoxicity from chemotherapy. And lastly, ovarian function suppression and aromatase inhibitor improves outcomes in premenopausal patients who also received adjuvant chemotherapy. So it is possible that the observed benefit from adjuvant chemotherapy in premenopausal patients with low intermediate recurrence score may be the result of endocrine effect with chemotherapy through ovarian function suppression. And of course, to address this hypothesis, we designed and running now the BR009 chemo offset trial. And with that, thank you very much for your attention.